So we're going to start. Thanks for everyone for joining. So this is a webinar, and we're going to talk about pain management, specifically period pains, and talk a bit about endometriosis. But as an introduction, I'm Dr. Pancholi. I'm one of the GPs with Boots Online Doctor. If you're not familiar with Boots Online Doctor, it's an online service where you're able to get prescribed medication as well as medical advice easily. You fill out a form and we'll review everything within 24 hours. If appropriate for you, you can pick up your prescription from any of the Boots stores, or it's free delivery. And this is Charlotte.
Thank you, Megha. So I'm Dr. Charlotte Small. I'm a consultant in pain management. I work in the NHS, but I also work for Leva Clinic, who are an online pain management clinic looking after adults based in the UK. We look after a wide range of pain conditions, including pelvic pain and endometriosis.
That's why we're here. Just to say, you can ask any questions anonymously. There's a question and answer function on this Zoom. You can also write in the chat. That's been moderated by Edna. So please feel free to message along. So as I said, we're going to focus on pelvic pain, period pain, and pain management. It's such a broad topic. But we'll hopefully have an overview. We can talk about medical management as well as non-medical management. We can talk about medical pathology as well. And at the end, we'll go through any questions that you may have. So what is pain, Charlotte? You talk to me about pain.
That's a great place to start. I think it's important just to remind everyone that neither of us are gynecologists. Yes. So we're going to focus very much on pain management of periods and then extending that into chronic pelvic pain conditions. So you're right, that's a great place to start. So what is pain? Well, pain is an unpleasant sensation. Almost all of us experience it at some point in time. We talk about pain being acute or chronic, and acute is short-term pain, generally related to either an injury or an illness, or if you've had surgery, but also includes pain when you're having your period, and sometimes before and after. Pain is there for a reason. It's designed to stop us doing things to get hurt, but also to help us heal when we are injured or damaged. It's a really unpleasant thing to live with, so we look at different ways of managing it effectively, but more commonly than not, it's all settled down within sort of 6 weeks or so. Pain that lasts beyond the injury healing or beyond our surgery or when we should be feeling better is termed chronic pain, and generally we talk about chronic pain as pain lasting more than 3 months, more than 6 months, but again, that very much depends on what's causing it. And within this, we're going to talk about chronic pelvic pain, of which endometriosis is probably the most common cause of chronic pelvic pain in women or people who are assigned female gender at birth. Chronic pain is equally unpleasant. We don't quite know why it happens. It's really, really common. We know that about a third of us are going to experience it at some point in our life, and about 10% of people are 10% of women of childbearing age are going to experience endometriosis. So it's amongst all of us. It's our friends, family, mums and daughters.
And we will talk about this a bit later, but I think it's the psychological impact that pain can have is really key, and we want to talk about that obviously today as well.
Yeah, absolutely.
Okay, so what is a period? What is normal period pain? As you said, pain is a normal part of life. And what is a period? So the lining of the womb builds up at different stages of your cycle, and when it sheds, the muscle of the womb contracts, and that can be mildly painful. I think we'll get onto like scaling pain a bit later. But you can get cramps associated with it. And in terms of when does that become abnormal, we'll talk about endometriosis after, but simple things that you can do to sort of manage a normal period pain. Patients coming in saying, I know you mentioned about like teenage patients coming in or patients coming in. So simple things like using a hot water bottle, warm bath, gentle exercises can be really helpful. And then talking about medical management for simple, just period pain, using medications like paracetamol, ibuprofen, and then hormonal treatment as well, which we'll talk about. But in terms of the endometriosis, so a normal period pain is something. Now, pain is obviously very subjective, it affects people in different ways, but when it starts affecting your quality of life, you're having to take time off work, you're having to stop doing activities you enjoy, certain sports that you enjoy, it's really affecting you psychologically, that is suggesting that possibly there is something else going on. You should go and see your GP to discuss this in more detail to get an assessment. And endometriosis is probably the most common cause of a pathological sort of really painful period. So what makes the endometriosis pain different is what I said in terms of it impacting the quality of your life, having to take time off work, etc., rather than it just being with your period and then it stops. And sort of, as Charlotte said, we're not gynecologists, and endometriosis is a specialist diagnosis, which is diagnosed by a gynecologist, but your GP can refer you if there is suspicion of this, and usually it's diagnosed with scans and ideally a laparoscopy as well. And following a diagnosis, in terms of the management of this pain, it kind of goes back to what I started in terms of it's treated with the severity, but the pain management should be individualized for each patient. So the first line is usually a short-term trial of oral painkillers, so non-steroidals, so things like ibuprofen and paracetamol, mefenamic acid is an option as well, and monitoring your response to this. There are also hormonal treatments that you can have. So this includes a contraceptive pill, the implant, coil. Now, it's important to understand that these are prescribed medications, and they themselves have got side effects associated with it. So it's important that you do discuss that with your GP, because there are, as I said, side effects associated with it. These are contraceptives as well, so they will affect the fertility at the time of taking that medication. In terms of fertility, it's important to know that with hormonal medicines, they don't have a long-term effect on your fertility. And then the non or other pharmacological options, which I think Charlotte's more experienced to talk about.
So we'll talk about those in a sec, but that's really interesting. So I've got an almost teenage daughter. Her and her friends are all now sort of starting their periods, and it's a time of life. There's a lot going on, a lot of changes, and for some people it can be quite a frightening thing to happen to you, particularly if you aren't aware. And we go to female family members and friends for advice. I think most people know that trying like simple painkillers can normally do the trick, can normally kind of get you through those few days. At what stage do you think people should go and see their GP for support?
So I think there is that thought of, oh, it's just a period, don't worry about it, and we won't go into that in detail. But as I said, when it's starting to impact the quality of your life, that's very subjective. What one person feels is disruptive to them is, somebody else may be able to manage that fine. But if you are finding that activities that you want to enjoy, so if there's certain sports you play or events that you go to, if you're having to cancel on social events, if you're having to take time off, absolutely, take time off work, take time off studying, just because of your pain, that would be concerning for me as a GP. If you're getting pain that's not stopping when your period stops, so getting pain outside of your cycle, if you're getting other symptoms, so bowel changes, urine changes, if you notice that your normal period is different, so if you feel that it's more heavier than normal, if you're getting more clots than normal, any changes to your normal period cycle, then you should go and discuss that with your GP. And when we're saying when you're having these symptoms, it doesn't mean you have endometriosis. It means that there's a suggestion that further tests or discussion even is required and needed. Because
there's a huge range of experience, isn't there? And some people can sail through their periods without any pain at all or any drama, and that's lovely. Some people have really quite unpleasant experiences that can start quite a time before and for a long while afterwards. And as you say, it depends very much on the sort of lifestyle that you live as to how it's impacted, and whether you're needing to take exams at school, or you're at college, or you're an athlete that needs to attend training. There's very kind of individual variation in terms of how it affects individuals, and that's why care needs to be individualized to make sure that we're looking at the right treatments for the right sort of for the right people. What conditions are GPs happy to treat, and what would you refer on generally for specialist treatment?
So, I mean, in terms of, as you said, it's first of all getting awareness of your own cycle and what's normal for you, what pain is normal for you. So we would usually start, if there is any of the pathological things, so bleeding outside of your cycle, bleeding after sex, a change in your normal bleeding pattern, or pain or outside of that period, and you're suspecting endometriosis or any other pelvic or gynecological pathology, then I would refer for specialist advice or investigation.
Is it useful to keep a diary then?
Absolutely. I think it's really important to get to know what your own period, what your own cycle is like. Days of bleeding, but as I said, it's not relating to bleeding. You can have either no bleeding or some bleeding and still get pain. So keeping a symptom diary, what time of the month you get the pain, what your bleeding pattern is like, when you get the pain, is there anything external triggering it? Is there anything internal triggering it? Which is really helpful as a GP to see if there is a cyclical pattern at certain times of your period that you get the pain, or whether it's there all the time. And that obviously will help either make a diagnosis or whether I need to refer someone on for further specialist care.
What about, we've mentioned about having a daughter who's at the start of this. What about with, my friends and I are all now entering into perimenopause and menopause. Can things get worse? Can my pain get worse as I get older?
Your pain, I kind of explain it as like when you're around the perimenopause, menopause cycle is similar to when you're at the teenage, like beginning cycle. Hormones kind of do go up and down, and periods do change at the sort of perimenopause and menopause. So patients do say, so perimenopause is when you're kind of around that time, and that can be months to years, and periods can be heavier, lighter, more frequent, less frequent, and pain is associated with that as well. So absolutely, answer your question.
And we'll talk about this in more detail later, but we know that pain is very much affected by your state of mind, by how much stress you're living through at the time. So certainly going through, when you're younger, going through all your exams and friendship changes and all the things that go with being a teenager, and then being older, maybe you're in a busy job or life is stressful, you're looking after parents, teenage children, and that can all influence how you experience your pain. You mentioned before about hormonal treatments. If I was wanting to think about that, what sort of risks would I need to think about?
So as I say, it's a prescribed treatment. So it's a discussion between you and your GP whether this is appropriate for you. But most commonly, people think of like the pill. There's two different types of pill. The combined, which is the estrogen and progesterone, and the progesterone only. And depending on your individual medical history, we would need to examine you and make an assessment to see if that's right for you. We're not going to talk about contraception today, but when we do prescribe a pill, we are prescribing it to treat the pain, because we know that can help. I won't go into detail as to how, but it does. But there are side effects with that as well. So it's a balance between managing pain, managing the symptoms associated with the pill versus the effect that it's going to have on your quality of life. And it's a contraception as well. So if you are trying to conceive, then that.
Yeah, absolutely. I mean, no medication is without risks and potential side effects, isn't there? And there will be some people for whom hormonal treatment is absolutely contraindicated because of a history of blood clots or cancer. But for some people, it can work really nicely.
Absolutely.
But it's very much a sort of try and see for lots of patients, isn't it?
I think that's the case with most things in medicine. There is a bit of element of trial and error. And it's important to know that if one form of treatment is not working for you, that doesn't mean that's not right for you. If one painkiller is not working for you, we can try an alternative. If one hormonal is not working for you, we can talk about other sort of pharmacological or non-pharmacological options for managing pain as well, which we will speak about as well.
So for sort of simple period pain, what's the impact of diet and exercise and good sleep on that?
I mean, I think that helps everything, isn't it? We're managing holistic patient care. So completely non-medical, nothing. So having a healthy diet, so looking at what you're eating, and inflammatory foods like sugar, we know can aggravate inflammatory conditions in the body. Exercise, and I think the type of exercise is questionable, but even just moving your body, light exercise, going for walks, we know can help. Simple things like hot water bottles, hot baths, those types of things have been really shown to reduce muscle tension, reduce health and pain as well. And I think with any pain condition, I'm sure you can elaborate, focusing on the holistic well-being, mindfulness, stress, you've mentioned a few times. Stress on the body is not just mental, it's physical as well. And it's important. I think that's where the symptom diary comes in as well. And you can look at diet and sleep and exercise and hydration and see if that's going to help.
It's helpful to look at yourself holistically. We know that there's certain things. So we know that, for example, being constipated can make pelvic pain feel worse. There's, the microbiome is the new buzzword at the moment. We were just having a look, weren't we? And actually there's emerging evidence, but there's nothing really solid at the moment to suggest one diet over another. Certainly the whole thoughts around exercise is really interesting on two aspects. One, if you're not used to moving around a lot, then moving around a bit can certainly help with your pain management. At the other end of that, we know people who do a lot of exercise, and particularly people who are professional athletes, can find that their performance can reduce during their period. So actually looking at, if you do train really hard, looking at modifying your program during your period can sometimes be helpful.
Absolutely.
So let's move on to talking about sort of, the other end of that spectrum. And this is my area of expertise where I would see patients. And I see patients often who have had problems with pelvic pain in their periods for years and years. We know that chronic pelvic pain can start to develop in adolescence. We know that it's very common. We think about 10% of women of potential childbearing age can suffer from endometriosis, and a large proportion of patients with pelvic pain suffer from are diagnosed with endometriosis as well. So it's just an example we're using, but it's probably the most common. Most people take about 5 to 10 years to get diagnosed. Again, as we've sort of alluded to, there's people normalised feeling pain during your periods. It's one of those things we're just expected to live with. And I think particularly adolescents and children presenting with pain are often not heard very well. So it can take quite a long time. It's a condition which has, an awful lot of misunderstandings around.
I think that's really important sorry to disrupt you, but knowing yourself and knowing what your cycle and your period is. I think it's really important that you have that awareness. So you're able to spot when something is different or something feels off.
And you're right. As we've said, period pain should be really just around the time of your period. So if we're thinking at the other end, so endometriosis is one of the pelvic pain conditions. It's diagnosed by either having pain all the time throughout your cycle, or sort of sporadic pain which comes and goes throughout your cycle, changes in bleeding, changes in other sorts of pain, so pain whilst you're passing water, whilst you're having a poo, that kind of thing. It's not supposed to be painful, but for some people it is. It can also come alongside other sort of painful conditions as well. So often patients who have chronic pelvic pain and endometriosis may well have irritable bowel syndromes, migraines, those sorts of pains as well. So we would be happy to start seeing people certainly who have been diagnosed with endometriosis, but also people who are suffering from difficult to manage chronic pelvic pain conditions.
So would you, so as a GP, obviously I can talk about pain, over-the-counter pain management, and like, as I said, ibuprofen, paracetamol, pills, hormonals. Would they have had to have completed that and then come and see you, or can they see you alongside, or at what stage would you want to be involved?
I mean, I think it depends. Certainly if you're talking, in terms of accessibility to pain management, that varies between NHS and private care. Private care, you can see someone whenever you want, really. The NHS have far stricter guidelines, which is important. I think two things. First thing, we'd like there to be a diagnosis. So to be seen in chronic pain clinic, we're not a diagnostic service really in terms of working out what the underlying cause for that is most of the time. So as you mentioned earlier, to diagnose endometriosis, we'd expect them either to do ultrasound, MRI scans. Majority of patients have laparoscopies, which is a camera examination under anaesthetic into the tummy to have a good look around, and actually then you can actually see normally patches of womb lining outside of the womb. So we see it on the bowel, on the bladder sometimes, and that's done by the gynecology team, and then we'd expect that team to then do their best possible care for you, and depending on the level of disease, how serious it is, that might involve specialist hormonal treatments, which are often sort of semi-permanent hormonal modification. A lot of time that involves surgery. Again, with caution, I often see people who have had lots and lots of surgery coming to me when actually some other alternative strategies could have been considered. Absolutely. I would hope that patients would have tried simple over-the-counter medications or GP prescribed before they came to us, because often there's quite a long wait, particularly in the NHS, for treatment. But, you know, also having to pay for private care, it would be really nice to make sure that patients aren't wasting their money by coming to us when they could have managed quite nicely on something over the counter. So absolutely, paracetamol, a non-steroidal medication like ibuprofen is, you know, a sensible start. And if you're then really struggling, to then come for some sort of specialist advice. GPs, as you know, range in confidence in terms of what they're happy to prescribe. So next line for painkillers or alternative medication for this sort of pain are a range of drugs that we commonly prescribe for what we call nerve pain, so neuropathic type pain. And they come from different classes, but generally they're antidepressant type drugs, anti-epileptics, or anticonvulsant type drugs as well. So they're used for all sorts of different types of pains. We're not using them for depression, and we're certainly not using them for epilepsy, but they include amitriptyline, duloxetine, gabapentin. They're worth a try, and for some patients we will try them, and I'm always supportive of them if patients want to try them. They are, like you were saying with hormonal treatments, they are not without side effects, and some worse than others. What's important is to take a really good history, so to really understand the type of pain the patient's got, because they work on the sort of nervy type pain, so that kind of burning, like really intense pain. What we know about endometriosis is that people suffer from lots of different types of pain actually as part of the condition. It's an inflammatory type of pain. So again, it can make you give you that kind of general unwellness feeling that, you know, an anti-inflammatory can work quite nicely. Sometimes neuropathic agents work really nice, but sometimes they don't work at all. It's not the right sort of pain. And also, as I've mentioned, some patients come to us having had lots of surgery, so they may well be suffering from what we call post-surgical pain, which can be scar pain due to adhesion, so your bowel sticking together. So what we would normally do is ask you in great detail what you're feeling, when you feel it, how cyclical it is, to then kind of tailor the medication to you. We try and avoid opiates if we absolutely can. So some patients will come to us already having tried opiates. Sometimes a very mild opiate like codeine can sometimes help, but they tend to they give you more side effects than benefits. The majority of the time, they're terrible for constipating you. They make you feel generally unwell. They affect your fertility. They affect your bone density. They're a horrible thing to be on long term. So apart from around the time of people having surgery, we do our absolute best to avoid them if at all possible.
I think it's echoing what I've said before in terms of there is an element of trial and error. We're using medicines which may be seen as, you know, epilepsy or that, but we're using it in a different way. But we know that the way they work, it can possibly help our patients. And sometimes a low dose of something can be life-changing, as we said.
Absolutely.
All right. So in terms of like myths around pelvic pain, I think it's a good way just to kind of summarize what we've said and kind of take the discussion elsewhere. So one of the myths is symptoms of endometriosis is just a heavy period. And I think hopefully we've kind of touched on this, that you can get pain even without a period. Your periods can be normal, your periods can be heavier, your periods can be lighter. As I said, especially even around the perimenopause, you have normal period changes. In teenage years, your periods can be sort of erratic as well. And so endometriosis, which is the lining of the uterus tissue outside of the womb, and the pain can be, you know, not associated with bleeding. So don't just, when we're asking patients to be mindful of their own period history, take a pain diary as well, because that doesn't have to be relating to that. I don't know if there's anything you want to add to that.
Yeah, I mean, you know, patients come to us with a whole myriad of symptoms. It can make you feel, you know, it makes you it affects your whole well-being, really. So it's I think by saying, you know, oh, it's just a heavy period, it very much minimizes what women are going through. And we know that if we know that 1 in 10 of women are experiencing this, then we know that there's probably a huge plethora of women who are underdiagnosed with this. So I think, you know, understanding that it can affect you in all sorts of different ways is really important in terms of tailoring treatment. It's important to know, though, that as a condition, as a chronic pain condition, the endometriosis process itself can change the way that your pain system works. So we talk about turning the volume up. So, and it's caused by lots of things. One of the things we think causes it is being in pain over and over and over again makes your pain system like super efficient. So so it makes your pain system, we use the term hypervigilant. So if you're like super switched on, so it makes your pain system behave a little bit like that. And we know that's true. That's due to changes within your brain in terms of how your brain processes your pain, but also changes with the nerves that supply the tissue that is abnormal. And we know, unfortunately, that often patients who have had all of that abnormal tissue removed surgically can still have pain. So again, a lot of the patients I see have had extensive surgery. They may well have had a hysterectomy, have had extensive hormonal manipulation, and are baffled that they still have pain. In fact, all of their care providers are baffled that they still have pain despite, you know, the disease having disappeared. And I hear a lot of, well, it must be in my head, I must have been imagining it, can't be real. And we know that's absolutely not true. The pain is completely real. It's just that it's your pain system that is causing the problems now, rather than the original condition that started it all off. So a lot of our strategies for supporting people with chronic pain work on turning your volume down, but making your pain system less hypervigilant. It does explain why a lot of the medication aren't particularly effective, because it's not what they were designed for in the first place. So we'll talk in a little while about sort of non-drug management of this.
I think that's really interesting. I think that's vindicating for a lot of patients as well, because I mean, you're a pain specialist, but as a GP, even patients coming in saying, I've had all this, I've done all this, and patients can say, am I going crazy? And it's like, no, absolutely not. As you said, that's really interesting. I've not come across that before. Okay. So the other myth I've got down here is that endometriosis only affects the pelvic region. I think we were discussing this earlier. It's really interesting that tissue can be found all over the abdominal cavity. So we know patients can have bowel changes, can have urine changes, bloating, and even it can be around the lung area we were talking about.
So really rarely you can get seeding of tissue, so where tissue's traveled elsewhere and it's within the chest. That is really rare, but it can sometimes happen. What's more common is that endometriosis pain sits alongside and probably sets off other pain conditions. So migraine, irritable bowel syndrome, a condition called fibromyalgia, which is a widespread muscular pain condition with other unpleasant symptoms. So all sorts of dizziness, vertigo, sleep problems. So we see endometriosis alongside lots of other painful conditions as well. So we treat that, you know, again, it's important where patients might be referred to us from gynecology, say, where they're very focused on the pelvis, and actually what we do is zoom out often and then look at you as a whole and talk about all your other pain.
I think that goes back to what we talked about, like the holistic care and looking at the
Yeah.
person as a whole, rather than, as you said,
Yeah.
just your endometriosis.
Yeah.
Okay. And this kind of links in, so I think you mentioned this briefly, is that the disease on the scans correlates with the level of pain. So I get patients coming in saying they had a laparoscopy, there's not that much endometriosis tissue, and so therefore I should be having very mild pain. Or the opposite, where there's a lot of endometriosis tissue and those patients sometimes are absolutely fine. So I think that links nicely to what you said.
Yeah, it's a sort of it's a rule in pain medicine where the level of injury or disease rarely correlates actually with the amount of pain suffered, and we see that across the spectrum of injuries and illnesses, and patients can have other conditions such as fibromyalgia where they come to us and say, oh, my tests are normal, but it just means we're looking in the wrong place normally, or there isn't a test available that shows the abnormality or shows the problem. And you're quite right, you can have a tiny spot of endometriosis, or it can have all been removed yet you still got terrible pain. Likewise, you could be having surgery for something else and we can see it and go, oh, that's interesting, the patient isn't suffering at all with it. So absolutely not. And this again comes back to this concern people have over specialists saying, oh, there's nothing more I can do for this because there's no more tissue to remove. GPs run out of medication to give you. It just means you're in front of the wrong professional. Probably, and that's where maybe moving into either a specialist pain clinic or a specialist endometriosis clinic, of which there are across the country, is a wise next step if you're still really stuck.
I think it can be massively frustrating as a patient as well, being told there's nothing else I can do. What else? And I think, we obviously wanted to have a talk just to talk generally. I think it's really important to get our patients to advocate for themselves as well, and say that, look, if one avenue is not helping you, there are other options available. Absolutely.
It is, living with chronic pain is utterly miserable, and by the time we've talked about the delay in diagnosis, by the time patients come to pain clinic, they're often years and years down the line, and that's true of many conditions we see. And patients are frustrated, upset, angry with healthcare because we haven't managed to deliver a cure. Chronic pain infiltrates every aspect of your life. It changes the way you feel about yourself. It affects your relationships, your ability to earn money, your ability to be a parent, friend, everything. It has such wide-ranging impacts on people's social mobility, social life, psychological well-being. We see a lot of co-diagnosis, so separate diagnosis of mental health conditions, when actually it's just misery. We know that for some patients, they have a history, for example, of childhood trauma, and that may well then drive, we think, some of the development of chronic pain conditions. So again, this is why if you come to a pain clinic, you'll probably see a multidisciplinary team. So we have nurses, psychologists, physiotherapists on our team. If you're referred into pain clinic or you see a clinic privately, they may well recommend what we call a pain management program, which is a multi-step education program, really, to help you understand about your pain, talk in more detail about some of the things we've talked about, so risk benefits of medication, diet and exercise, how to reduce the volume of your pain. And again, that should ideally be tailored to the patient, depending on the program. Some are a bit one size fits all, but it also can give you a sense of community, that you're not the only one out there. So and that's where, for some patients, we recommend psychological therapies such as cognitive behavioural therapy, because it can help give you some tools to help you live better alongside your pain. Certain things like mindfulness we find can meaningfully reduce the pain that you're experiencing, but it's very, very much not a one size fits all for everyone.
Absolutely. I think the psychological impact, as you mentioned a few times, and we've talked about it as well, is massive. And especially if you go to a GP or specialist or someone and you're kind of not getting the help or the treatment, or you are getting the treatment, it's not really working, to know that maybe it's just not the right thing for you yet, and we just need to find something else.
And it's different treatments at different stages of life as well. You know, it's we've talked about impacts on relationship. It'll affect your sex life if it's painful. It may well affect your ability to have children, affects your ability when you're older, affects your work. So again, being able to tailor treatment according to the stage of your life is really important, and that's where having a multi-specialist, multidisciplinary approach to consider you holistically is really important, and that can be delivered both within the private sector and the NHS.
Okay. Was there anything else you want to tell me, or you think that we should talk about before we go to the questions with regards to, you know, the medical side has not worked for the patient, they're taking anti-inflammatories, or maybe they are on a contraceptive pill. Is there any other sort of top tips or anything that sort of comes at the end?
I think, you know, my overall take-home message is that it is a 50-50 balance of keep asking questions. You know, it is an evolving field of medicine. We don't have all the answers. Anybody who says that they understand how to get rid of pain or why we have it in the first place is not telling the truth. We don't understand yet. We've got a growing knowledge. So keep asking, but at the same time, empower yourself, learn about your own body, learn what helps you, and then hopefully that, you know, combining the two can, you know, help you move forward eventually. But it does, you know, it is a really, we appreciate it's a really, really difficult thing for people to live with. So
that echoes my sort of final thoughts before we move on to the questions. It's advocating for yourself, isn't it? I know it can be really daunting. Patients come and discuss their periods with me and pain that they're experiencing. And unfortunately, patients do, you know, there is a lot of dismissal and stigma associated with it. So keeping a symptom diary, knowing what's right for you and advocating for yourself, something doesn't feel right. And if you've tried certain medications, certain painkillers, they're not working for you, know that there are other options and treatments available for you. So if one thing doesn't work, don't think that that's it. And just talking and looking at the psychological aspects. So I think it's really important. Okay, I think there's a lot of activity. So we're just going to ask, check on the chat. You click on the Q&A there. Okay. So got a question here. What are your thoughts on seed cycling to support period pain management, i.e. natural methods to help aid period pain? I don't have any.
Well, so there are
natural.
There's a huge range of natural remedies out there nowadays. I think the important thing from a doctor's point of view to point out is that they're not evidence-based. What does that mean? That means no one's done a big trial to assess whether they're better than standard care, so paracetamol, ibuprofen, or that they're safe. So having said that, there aren't going to be big research studies for every potential treatment option that comes out. So I think having some common sense around, is this a safe thing to start? Discussing with your GP is always a sensible first step. But this is back to what we were talking about. It's everything is worth a try generally, because individuals' pain and their response and how their pain system responds is so different. We find that one thing might work beautifully for someone and not work at all for someone else. So yes, absolutely. And bearing in mind, you know, as I said, we've got growing knowledge around the subject. So people, you know, treatment evolves through people trying things, and as long as it's something that is, you know, safe and sensible, then and that's why asking your GP. But absolutely, I'd always advocate for people to try. You know,
the only thing I would say is obviously it's very individual. So depending on your own medical history, what medications you're taking, it is advisable that you do discuss that with your GP first to make sure there's no contraindications. Okay. So there's a question here. Would you have any advice for someone who has consistently had different contraceptives issued to manage pain / stop periods altogether but is running out of options and still has pain regardless of bleeding? I think that's a very common and very good question to discuss.
So I'd be assuming that this would then fit into the chronic pain
Absolutely.
paradigm, because this sounds like someone who's having pain either continually or maybe despite having contraceptive medication to stop their periods are still getting pain. So I think going back to your GP, asking for referral to a gynecologist to get specialist assessment would be a sensible next step for this, because there are more treatments available.
Yeah, I mean, as a GP as well, if a patient is still getting pain despite what they've done so far, I would definitely refer here.
Okay, so this is a sensible one. So at the peak of my endo pain, I take codeine, paracetamol, and naproxen, have a hot water bottle and heat pad, but these don't work and make me feel nauseous. What else could I do? Yeah, I mean, this is the problem with painkillers, that codeine in particular, naproxen, can make you feel sick and give you more side effects. I'm assuming you haven't seen a pain specialist about this, so you could consider starting one of the other types of painkillers that I talked about before, so something like amitriptyline, gabapentin. So either going back to your GP and seeing if they would be happy to prescribe those for you on a trial. Again, some of them have side effects, but it's often worth trying them. We say about 6 to 8 weeks, and then potentially referral on to a specialist pain service. The NICE guidelines say that everybody diagnosed with endometriosis should have access to a pain management service. So, and they are almost always hospital based. So, go to your GP, get referred. We'd want to see you, even if you're sort of managing, and this is the problem in chronic pain clinic, often people think that our threshold for seeing patients is so high that we'll only see people who are bedbound or totally unable to get to work. We know that our endo patients are highly motivated. They're often busy working mums, living their lives despite their pain, but we'd still want to see you. We can still improve people's quality of lives.
I think that's what I mentioned to you when I first met. It was like a pain clinic. You assume that you have to be kind of bedbound, not able to move to kind of get that special treatment. But I think what you said, like the simple things as GP that I can prescribe more than what this patient has had. So it's just going back and having the conversation, isn't it?
Absolutely. And chronic pain services differ throughout the country. So throughout the UK, because they are commissioned and staffed variably. But there are private providers. So Leva provide an online pain management program, and we'll see patients. And certainly the Boots team know about private providers who can refer on if you don't have a suitable local service. But try your GP first.
Okay. I like this one. How can we push to have women's health issues taken more seriously and have more research done on period-related disorders? I mean, hopefully we're talking about it today. There's it is Endometriosis Awareness Month, so hopefully you've seen lots of media bits, and social media I think is very vocal in terms of, if anything, if this talk makes people keep a symptom diary and just aware of their own bodies and their own cycle to say something's wrong, that's a good start.
It is a good start. And I mean, it's why we're here, isn't it? We're here to sort of advocate and to talk about this. I think on one side, I'd be reassured that there is research going out there. We were looking earlier at trials that are happening, looking at surgical options, hormonal options. Unfortunately, these trials can take 5 to 10 years to bear results. So progress is often slow, and that means it's done safely. We're not making things up as we go along, but there's other charities. Endometriosis UK are very good, so supporting those. But absolutely, it's as someone said, people sort of expect periods to be a small thing and not really to bother us and just sort of carry on. But we're here to raise awareness of these things.
Well, that links nicely to the next question. What about the myth that periods shouldn't be painful at all? And I think I want to add it here that I think, as you said, pain is very subjective, and what one person experiences is different to what another person experiences. As a GP, just as a sort of summary, I would say if a patient is, as I said, cancelling events, not going out, taking days off work regularly because it's just their period, that doesn't sound normal to me.
No, I think it's the opposite. I think it's not that we think that people think that they shouldn't be painful. I think that people think that they are painful, but that we should just put up with it, that it's something that we shouldn't complain about, that we should just carry on as normal. And certainly, you know, the last thing we want to do is for every woman listening here to be thinking, right, I need to go and see my GP, or for all my daughter's friends to all be terrified that they're going to develop this terrible chronic pain condition. For the majority, so for, you know, 80–90% of women, they, you know, we suffer from pain, and but it's managed effectively with simple techniques. So paracetamol, non-steroidal, gentle exercise, sensible diet, early nights, you know, reducing your stress levels. So for most people, that's absolutely fine. We don't want to pathologize it, but at the same time, we do want to recognize and identify that people who are having life affecting issues should be listened to. Yeah.
So what are the best tools for pain whilst on holiday?
That's an excellent question. I get asked that a lot. So firstly, so I'm assuming you're going somewhere nice on holiday. Firstly, we often find that people's pain reduces whilst they're on holiday, especially if you're going somewhere hot, or you're going somewhere where you're not having to be worried so much about work, and your stress levels are reduced, and you're having a nice time. Having said that, particularly for period-related pain, where there might be an anxiety around when my period's going to start, when I'm going away, I need to, you know, this is my 1 week of the year, I'm supposed to be having a nice time. There is also the consideration of, if you're going to certain countries, you might not be able to take your painkillers with you. So some countries restrict types of drugs that you can take. So it depends a little bit on where you're going. I would always say take a backup plan with you. You'll be able to advise more on this, but certainly if you were going away and worried about having a period, you can take short courses of hormonal treatment, can't you?
So we do have treatments available for period delay, as well as hormonal, we say contraception, but as I said, you can use a medicine for a different thing. These are prescribed. You would need to discuss that to see if it's appropriate for you with your GP. But certainly if you want to take a short course of hormonal treatment whilst you are on holiday, that is a very common tool that we use.
Yeah. So this is a good one. So do you have any advice for someone who's been asked by a doctor in the past if they think the pain is all in their head? It's caused me to completely lose confidence that I'll ever be able to get a diagnosis. It is really sad. And I think when we talk about all in their head, and in fact there's a book about this, but I think what people mean when they say this is that they think it's fabricated, so they think it's made up. I hear this all the time in clinic. I've been told it's all in my head. I think it must be all in my head, because it doesn't make sense. Because we understand that, you know, you see an injury and it hurts and it gets better and the pain goes away, or maybe you've got your period and you think, well, I know that hurts a bit, so, you know, once it's gone away, then, you know, the pain should settle. It's important to understand that, and this will sound daft, your brain is in your head, and part of the issue with chronic pain conditions is that the part of your brain that regulates how you feel pain, what the pain means to you, that whole, we're talking about dialing up the pain, that is in the center of your brain. And actually that has the ability, that system, to generate pain all by itself. So that pain is real. It is generated by your pain system as a consequence of lots of things. And again, we're not quite sure why it happens. We know that it's linked to hormonal factors, inflammation, the fact that you've been experiencing pain over and over again. So just because it's generated by your pain system going a bit wrong doesn't mean it's not real. It's as real as anything. And actually they've done functional MRI scans, so specific scans within research settings that have shown differences in that part of the brain. We don't do that in the NHS in terms of that sort of test, but it's a huge leap for people, medical professionals alike, actually, to say there is
nothing
to see, there's no damage to see, but there's still pain. But that is what chronic pain is, and generally.
That's really frustrating. I see patients, they've had their scans, they've, you know, ultrasounds come back normal, laparoscopy, and we talked about this earlier, it doesn't correlate to the disease. And I think it's really empowering that you said that, and just to echo to patients, the pain is real. Like
It's
you're
it's
experiencing
the same
that.
as saying that your brain scan is normal, yet you've still got depression.
Yeah.
You know, it doesn't mean it's not there. It just means that that test can't see it. And one day we'll probably have the right tests where we can look at the right part of the pain system and go, oh, that's lit up, or oh, that's not quite right. But we're not quite there yet. But please be reassured that if you come and see a specialist, we firstly will believe you. Fabricated pain, so people who are making it up, is rare as rare. You know, I've probably seen, you know, patients who have confessed to that on one hand, if that. We will believe you. We know it's a real condition. We know that you can have both, so you can have you know, as we talked about, lots of disease and mild pain. You can have some disease and really awful pain. You can have no disease at all and terrible pain, and that is our norm. That is what we see, and that's where we look at approaches to try and again modify that part of your brain to get things settling down. Actually, the next question is really important. It asks about can endometriosis cause pain in your joints? Yeah, absolutely, because what it does is it turns up the volume of your pain system, and we often see other painful conditions. So that I would be thinking about something like fibromyalgia, which is a widespread, generally muscular pain condition, but can cause other symptoms, so pins and needles. And we know that endometriosis sits alongside but can switch on that pain. There's also an association between endometriosis and developing arthritis. So the two can certainly, they often sit kind of side by side with each other. So, and this is where holistic patient-centered care is really important, because you can have, just because you've got one painful condition doesn't mean you don't have two. So you can have endometriosis and arthritis. Just because you've got one thing doesn't mean that you then you know, that's it. You can't have anything else.
And
so
going back to holistic, you're managing the holistic patient's pain, not just their endometriosis or their joint. You're doing everything. Okay, so this is, I think it's just general pain management. The question here: if you are trying to conceive but suffer from endometriosis, what's the best way to manage the pain? So, as I said, the hormonal contraceptions is one avenue that we use to manage pain. So, kind of going to simple things, as we talked about, like lifestyle things, hot water bottles, or those types of things. If it's getting severe, you may want to look at anti-inflammatory medications, paracetamol, or any other of the sort of painkiller tablets that you spoke about.
Absolutely. And if you come to clinic and you're talking about trying to conceive, we will modify your medication or modify approach based on that. So reassuringly, for a lot of people, pregnancy settles down their endometriosis either for a short period of time or for a long time afterwards. There are medications we don't like you to take whilst you're pregnant, so we probably wouldn't start something if we knew that you were planning on trying to conceive. Likewise, we wouldn't withhold things from you when we understand that conception can take quite a long time. So again, it very much depends on your personal circumstances, but it is a common thing for us to be talking about in clinic. So we often have babies in pain clinic, and we will take you through that journey of trying to conceive, managing your pain during pregnancy, and then afterwards again.
I think as a GP as well, I would always want to know sort of the patients, if they're trying to conceive, and making sure even the over-the-counter medication that I'm advising is appropriate for you. Okay, I can answer. So can the hormonal coil cause pelvic pain? So the coil is, it's inserted inside the womb. So if you are getting pain associated with the coil, especially if it's quite recently inserted, you should definitely speak to your GP. The coil itself, if it's placed in the right area, the right place, shouldn't cause pain. So if you're having pain with your coil, I would advise that you see your GP just to make sure that there's no scans or anything else going on with that coil, because they're not common, but they can move. It's a foreign body. The human body doesn't like things inside of it that's not meant to be there. So sometimes the body can react in certain ways. So if you are getting pain with your coil, please do see your GP.
So my sister has endometriosis. Does that mean that the symptoms can also, that my symptoms, I assume, can also be related to endometriosis? Not sure if it's possible that it runs in the family. So it does. They've done what we call twin studies, where they take one twin with a condition and look at whether the other twin does. So obviously these are twins who are genetically identical, and find that about 50% match up. So absolutely, for sure, it can certainly run in families. We know that, like a lot of these conditions, there's probably a number of genes that may make you more likely to have it. They haven't identified those genes yet. There's still work going on in the background. But absolutely, there's no reason why it couldn't run in families, and it often does, and it often runs down sort of generations as well.
Okay. This is an easy one. What about medications such as mefenamic acid and tranexamic acid? Great medicines. So as I said, in terms of mefenamic acid, anti-inflammatory medications, very common medicine, which can be very effective in managing painful periods. Tranexamic acid as well can help lighten the period as well. So you take that at the time of your period. These are prescription medications, so you do need to either fill out a consultation or see your GP, but these can be very useful.
Super, you're probably better off answering that. So my daughter has very painful periods, 16 years old, and the only thing the GP offered was the pill, which didn't work. So we're talking about accessibility to adult services. I think this is what we were saying earlier, that often this presents in adolescence, and periods can be really difficult around this age. So what do you do if you're a teenager?
It's so hard and difficult, and again, we do see this in face-to-face GP as well. I think I'm a bit worried that the only thing the GP offered was the pill. Just going back to, I mean, I'm presuming that the patient has tried the simple painkillers that we've talked about. We've talked about it a lot, but there's different types of pills. You know, if one pill doesn't work for you, then maybe something else will help. In terms of I think it's quite vague. We don't have much information which did not work. You know, is the patient getting pain outside of a period? Is she taking time off school? Is her concentration work grades affected? In which case, do I need to refer to a gynecologist here at this age? There's lots of
I think it's, you know, it's important to know that, as with all of us in the medical profession, we all have specialist interests, don't we? So, you know, you've got a special interest in management of pelvic pain and periods, so actually you'd be the best person to go to within your team. So sometimes going and asking for a second opinion from another GP, or asking to see a specialist. Children's services are difficult to access sometimes. There's limited services for adolescents for gynecology and for pain management. Actually, not every region has them. But I think certainly this is what we're saying. This, you know, people need to start pushing earlier, and it's difficult to kind of know at what point to start doing that. But I think if she's, you know, unable to go to college or school, or unable to do the things she wants to, and it's really affecting her quality of life, then going back and asking again.
Yeah, I like what you said as well, that I think pain clinic and specialists is different, but even within GP, as you said, we all know and have our own specialities. And within your surgery, if you feel that you want a second opinion, by all means, please do that. And if my patient wanted to go and see another GP, I would be happy, because you know, they might have a different specialist interest. Okay. So is painful sex linked to painful periods, and does it mean that you have endometriosis if you have both?
I think it means that you might do. So it's a part of the diagnostic classification for endometriosis. So it's one of the 5 things that they list. So pain on sex, as well as pain on urinating and pain on defecating. So pain when you're having a wee or a poo, but also chronic pelvic pain. So pain during the rest of your cycle. So absolutely, it doesn't necessarily mean it's that. And that's where, you know, there's lots of reasons for painful sex. So it's important to go and see your GP or see a specialist if you need to privately, and they can take a proper history, examine you if it's appropriate. So that's never a given, because absolutely it's one of the most common things that we see, and it's really difficult for people to talk about as well. I mean, often, so finding someone that you're comfortable with, but please don't worry that it's, you know, going and talking about that means that you're definitely going to be examined. It's very much on a kind of what's right for you moment. So please.
I mean, as a GP, I mean, there's certain symptoms that we would not be worried about, but would definitely want to discuss and assess clinically, and pain during sex is definitely one of them that I would want to assess and examine if appropriate, as you said.
So final question, I have pain and burning sensation on my vulva for many days a month, especially after my period. What can I do to raise this to a specialist? I've been to see my GP before, but nothing was sorted as my swabs were all negative for STDs. So again, this is really interesting. This is something that may be rare for the GP to see, but actually is pretty common in pain clinics. So we see all sorts of weird and wonderful pains in all sorts of strange places. This sounds like what I call a neuropathic type pain, and you can get neuropathic pains in all sorts of parts of your body. So and it is not uncommon in my clinic to see it in the genital area in men and women. There's a range of medications I would want to try potentially. Sometimes we use local anesthetic and steroid nerve blocks, very rarely, but there are all sorts of approaches. So I think go back to your GP, ask for referral to a pain management clinic, or see someone who's seen another GP who's more confident with managing this sort of condition, because there are medications that can potentially help.
Okay, so we've come to 2 o'clock. Thank you for the discussion, but thank you for your questions. So many great discussions, and I hopefully you feel empowered, you feel we've helped you in some way. And I think just having the conversation, that was my thing. As long as we're talking about it and you feel motivated to advocate for yourself, that's good enough. But hopefully we've given you more than that. I just want to finish off by saying thank you. For Boots Online Doctor, we do have a period pain service. If you are wanting medical advice or treatment, you can fill out a consultation form, and we can advise you further. And just to let you know, there is a 20% off promotion for endometriosis this month. Fabulous. You want to finalise or?
Brilliant. Yeah, so thank you. So it's been lovely. Thank you, Megha, for having me, and thank you, Boots Online. It's been fantastic.
Thank you. Wish you all the best. There are links to both of the pain clinic and Boots Online Doctor in the chat. So if you are interested, please do have a look.